Hello, everyone.
Hello. Good afternoon to all.
Good afternoon.
Can you hear us? Dr. Saurabh?
Yeah. Yes.
Let us start our session. Good afternoon to all. We welcome you all to the next echo session. So today we are going to discuss about medical ethics. Dr. Sunil to introduce today's faculty.
I'm very happy to introduce Dr. Gayathri, who is one of my teacher and had the luck to work together. Currently, she is working as the associate professor in Menji Institute of Oncology, and she is the director of PACS Asia program to World Cancer Association Canada, and she is also a member of director of IHPC. And she is a very well-known palliative care physician in India. I welcome Dr. Gayathri and request you to kindly take over the session. One more request, all those who are not speaking, kindly mute your audio. And only when you speak, then you unmute the audio.
Very good evening to all of you. I think I'm just looking at the names who have joined us in this discussion. I'm not very sure that I know most of you, but can you hear me, Sunil?
Yeah.
Am I audible?
Yeah,
thank you. Thank you, Sunil, for the kind introduction. And but as we go along, and Sunil, is it 1 hour, 30 minutes, or 1 hour? How long is this?
You can go for 30 minutes followed by discussion.
How much time for discussion?
Maybe 15-20 minutes, and there will be a case presentation followed by that, and then based on that there will be again discussion.
Okay, great. Yeah, sure. So today I've been asked to discuss with you about ethics in palliative care. Now this is a session. Normally, I prefer to have it more interactive and more face-to-face, because as we go along, you'll realize that it's a very nebulous subject, and even you must be wondering, like, what's so different? Why are we discussing ethics in palliative care? All of you are already familiar with ethics generally in medical practice. So just to get an overview about what we are looking at and why it is so important in palliative care, I'll just start with a brief introduction of its relevance in palliative care. Next slide. So generally, next slide. Generally, when we talk about ethics, what's the thought? What do you mean by ethics? What is the thought which comes to our mind? Generally, when we say ethics, it's often about our beliefs and principle about what is right or what is wrong. It applies generally to our day-to-day life. It necessarily doesn't mean that in medicine we practice ethics. We always say I should be ethically right in what I am doing, and it's often guided by certain things, and that makes it what is right or what is wrong. Next slide. And next slide.
Madam, 1 minute.
Sorry, there'll be some delay about moving the slide, I have a feeling. Yeah, and as I said, our day-to-day ethics or day-to-day living is governed by many things. Our culture, our ethic, our law, morality, religion, how we grow up, how is our society. A lot of society thinks is also governs what makes it right or what makes it wrong. So all of these things put together, we decide that, okay, this is what ethics is. Now, next slide. When we talk about medical ethics, it's just an extension of that. Next slide. When we say medical ethics or bioethics, also known as bioethics, it is study and employment of moral values in medical science. And it applies in clinical care, but also a lot we do many of you must be involved in clinical research, and that's where we mostly talk about ethics. But it is applicable even in our clinical day-to-day clinical care. Next slide. Next slide. We just go. Sorry, the animation is there a lot of, so that's a confusion. Can we go to next one? Because I'm not controlling it myself. When you speak about medical ethics, as I said, often when you talk about ethics, it's often about research. No, there are many areas where the scope of thinking about medical ethics. Areas like ethical practice, are we doing ethical practice? A breach of medical ethics, any medical breach of ethical dilemma. We're going to discuss a little bit more about ethical dilemma which we often face in palliative care, and conflict. Sometimes when there's a conflict, we don't know what is right, what is wrong, and those are the areas where we don't know how to go about it, and we think about what is a right ethical practice. Next slide. I just thought, I know that there's a case presentation, but just to make my case about the ground work about ethics, or the ground rule we set for ethics, I thought I'll just start with one case study as an example. And this is a case study about a young man with 21 years, and he has relapsed acute myeloid leukemia. He has AML, and it's relapse. Can I see the slide?
1 minute, 1 minute.
Yeah. Can we have slideshow? So here is if you can have a slideshow, it will be better. And this is a young man, 21 years, and he has relapsed AML. He's now started bleeding from the nose, gums, and fatigue all over the body. So just 1 week ago, he received platelet and blood transfusion. And now, there's some confusion about.
Madam, is this the next slide? Can you see?
Yeah, but it's a half. It's like kind of, there's a notes. I don't want notes. Can we cut that notes part of it? Because I just see half of the slide. Yeah. Sorry, this is a technical issue. And yeah. Yeah, that's nice. So can we go to the case study? Can we go to the previous slide? Previous slide. Yeah, thank you. Now, as I discussed, he received platelet and blood Paxil a week ago. Because he started bleeding again, relatives are saying, give some more blood transfusion. Now, this is very difficult, very tricky now. He's a relapsed AML. If it's just 1 week, and again he has started bleeding. If you give blood transfusion, it didn't even last for a week time. So what is the rationale of giving more blood transfusion? Is there any meaning to give more blood transfusion? But what is the benefit if you give more blood transfusion? But we all know that repeated blood transfusion also is not very helpful. Many times it can lead to more problems than doing good. And especially when the patient is nearing end of life care, are we in any way improving his quality of life by giving this blood transfusion? This is a very classic example which we see in day-to-day practice. So how do we decide what is right or what is wrong in this situation? Now here, before you even tell the relatives, even explain to the relatives, we must have a clarity about what is the right way to help this young man and how to explain, how to guide the relatives appropriately. Next slide. So how do we go, what is the thing which helps us to make a rational decision about this patient? So there are certain guiding principles which we all follow in a medical practice. I'm sure all of you are very familiar with this in your during your undergraduate medical school training. You would have undergone this training, but just rethinking and revisiting these basic principles of medical ethics, which helps us to take a rational medical decision. The first one is patient autonomy. The patient involved in decision making. Patient's wish. What does that patient want? Next slide. It's derived, the autonomy word itself is derived from the Greek word self-rule. What does the patient want? It's my body. What is that I want to do about myself, about my body? Next slide. Let me make my own decisions. Next slide. So when you're practicing autonomy, there are certain things we must remember. What is that? How do a person practice autonomy? Autonomy happens only if respect for autonomy requires the doctor to provide full information in language and wording that promote patient understanding. A patient can exercise autonomy only if he fully understands. It is explained to him the implication of the entire gamut or whatever you're doing in terms of intervention in the language and wording that patient understands. Next slide. But at the same time, the previous slide. At the same time, it is also very important that the patient has a capacity to make decision. Patient, he receives information and also has that required mental capacity to exercise that autonomy. So both are important when we say patient autonomy: the ability to understand and the opportunity to be given that information. That both are important. This is relevant because when you speak about advanced diseases and stage diseases, many a time patients' the mental capacity becomes very diminished or sluggish because of various reasons. And many times we have this ethical dilemma: is the patient aware of what is happening to him? Can he take a decision? So that's where it applies, the patient's autonomy. Next slide. The other guiding principle is doing good. Whatever you're doing, of course, all of us, as a doctor, as a physician, as a nurse, when we do something, we always with the intention that we want to do good to the patient. But when you're doing that, what are the things which we must remember? Next slide. Futile care. What do you mean by futile care? Many times we think all the treatment, it's a treatment, we keep saying. We are driven by giving that treatment. There's something called futile care. In a very technical definition, futile care is whenever we are giving a medical intervention, a medical care, the goal of medical care is to achieve a benefit above certain minimum threshold. There should be at least minimum benefit we must get out of above the threshold before we say, yes, this is a medical care. That is the purpose of giving this treatment. Next slide. But when we say futile care which fails to provide that benefit, that at least that minimum benefit is also not achieved, then it is a futile care. It's a very technical definition. Next slide. But it applies in many a situation in our practice. But now the benefit. The question is benefit. Who decides what is beneficial? As a doctor, when I'm looking at the count, and the count goes up from 30,000 platelet to 70,000 platelet. Is that a benefit? Or the benefit is a patient's perspective. We all know that benefit, ultimately it is patient's perspective, and it's a very subjective concept. Benefit, when you decide benefit, it's not just 30,000 to 70,000. Is a patient feeling better because of that? That is the benefit, and that guides a futile treatment. And physician's benefit may be very different from that patient's benefit. So whenever you are in dilemma and you're not very sure that's doing good to the patient, find out from the patient whether this benefit, did that blood transfusion benefit him or not. Next slide. And as I said, it's best to go by patient's benefit. Next slide. The third principle, do no harm. So do good, but at least do not produce more harm. And many interventions, sometimes we'll end up doing there's a lot of problems which arise because of our intervention, produces more harm than doing good to the patient. Next slide. So we have to balance between doing good and doing more harm. And does the treatment have many physical side effects which outweighs the benefit? We have to think about that. And it's not just about the physical symptoms. Sometimes our interventions can have a multidimensional impact. It can have a social impact, emotional, financial, and physical impact. So when you talk about are we doing more harm, we have to have a kind of this full spectrum in our mind when we are thinking that is it producing more harm to the patient. Next slide. And the fourth and the final guiding most important, one of the important guiding principle is justice, balancing the need of the individual with that of the society. So when we say justice, it is about the resources. Are we justified in using the resources? When we are using blood transfusion, for example, I say, okay, now you need to give 2 more packed cells and 2 more platelet. The family goes back, again tries to find the resources to raise that money to give that 1 more of that episode of blood transfusion, which means that the patient will require hospitalization, and the family will find means to raise money because they may not have left with anything, because AML treatment over, spent a lot of money doing the treatment, now left with no money. Now this 1 more expenditure. So they may sell that little piece of land and then get the money and do this blood transfusion. And for what benefit? Did the benefit, how long did the benefit help the patient? Is this a fair allocation of hospital resources? Suppose this blood which I asked for, it was required for a patient undergoing surgery where there's a chance that he may get cured. So is it all right to use that precious blood on this patient who's bleeding and whose effect is only going to last for 2-3 days and again it's going to bleed again, versus a patient who's undergoing surgery? Second way of looking at is fair utilization of family's resources. By selling that piece of land, the children may lose their opportunity to have something for the future just because of this one patient who may require blood transfusion. And fair utilization of society's resources. In general, somewhere we are using the nation's resources. So as a whole, how justified are we in using resources when we are taking these decisions? Next slide. So coming back to this patient, it's a difficult question. Are we justified in giving this 21-year-old relapsed AML who's bleeding again and again blood transfusion? When we are not very sure, just take into consideration all these 4 principles of medical ethics. What does that patient want? Is the benefit perceivable to the patient? How much the patient feels, yes, it's benefiting me? Is it producing more harm to the patient? Because every time blood transfusion, 1 more needle prick, and patients post chemotherapy, it's so difficult to find veins, extremely painful procedures. And when you ask the patient, they say, just leave me alone, I don't want this anymore. So are we producing more harm, and how justified are we in utilizing the resources? So this is in general how we take decision about making a difficult decision when we are faced in a day-to-day practice. Like I started off in the beginning, why are we discussing medical ethics in palliative care? What is so special about it? When we are dealing with end-of-life care or dealing with patients with very limited capacity, who are very frail and in a very compromised state of condition, we face this dilemma every day in various forms. Informed consent. When patient does not have a mental capacity, when we do any procedure, can they give informed consent? Sharing of information. Very often relatives or the doctors feel that we should not be telling the patient. Patient should be shielded from this information. But are we right in doing that? Does patient need to know what is happening to him? Hydration and nutrition. Relevance of feeding, total parental nutrition, IV fluids in advanced care, is there any relevance for that? Cardiopulmonary resuscitation. Ventilation, is there any rationale of, suppose a patient with advanced malignancy, lung cancer, both lungs damaged, he's dyspneic and saturation is falling, are we justified in putting him on ventilation? Is there what is the outcome of this? Another difficult decision. Withholding or withdrawal of life support, a very debatable, and whether it's so much in discussion these days. Government of India is looking at various aspects of its benefits and making whether to make it legal or not. It's a very tricky situation. Decision making, clinical decision. When doctors ourselves, sometimes we don't know whatever that's. But should we go for this further second line chemo? Often it's very tricky. Resource allocation when we are dealing with terminally ill, and research. The research in palliative care itself is a big, tricky area where we don't know. Research is very limited in palliative care, but if you really want to have best practice, evidence-based practice, we need to do research. But how we cannot apply the principles which we normally apply on healthy patients on palliative care patients. So all this leads to a lot of conflict and dilemma in palliative care. Next slide. Decisions in palliative care setting are often made in an environment of emotional distress. A lot of emotions place when we're dealing in palliative care. Doctors should be sensitive to the human vulnerability, dependency, and fragility of the patient who's critically ill, and to the family member who are acting as proxy. They're all very, very emotional, and they're very vulnerable. In that situation, when you make decisions, often it is very much more complicated. It's not very so straightforward. Next slide. Often there's no right or wrong answer. It's very thin line between this side or that side. We are not very sure what is right, but we need to guide them because they're themselves very vulnerable and they're looking at us to make that right decision. And so often we have to make that decision sometimes. We have to help them to make that decision. So when you're stuck, there's no right or wrong. And first of all, we have to understand that there's no black and white in this. Next slide. The only way we can look at it is, again, as I said, there's taking a balanced, compromise view about all the four aspects of ethics. Next slide. When you're not very sure, the two things really helps. Next slide. When you, in spite of all these four cardinal principles of ethics, previous slide, when you talk about when you're not very sure, ask this question: what if it were me? And that will be maybe very helpful for yourself to make you have a clarity in your mind about what would be right for that patient. What if it were for me? And when you have some clarity about it, another thing which will be the key to the whole thing. Next slide. And I want to end with that. And with this message, can we go to the next slide? The key to the whole thing is that once you know that this is what would be best in the prevailing situation, give the choice to the patient and the family, and it should be informed choice. There has to be communication, open communication. They should be given the choice, and they should make that choice based on the information they receive, and it should be shared decision making. Once you do that, then often there is more consensus, less of regrets, less of guilt, and less of conflict, because that is one thing which often leads to problem. Less of conflict when there's a shared decision making. And with this thought, I just end my presentation. I open this for discussion.
Saurabh, I think there are some problem with your audio, or maybe with headphone. It's making a lot of noise.
My audio?
Yeah.
Okay.
Anyone want to ask any questions, Dr. Gayathri?
Thank you, ma'am, for the presentation. Ma'am, presentation has addressed many points, but everywhere a question mark is being left. Means practically, I would like to ask how you deal with such situations, and what is the right time for taking an informed decision. suppose when we come across a patient who is in a state of cancer at an advanced stage, we know that from treatment part of view, nothing much can be done, and palliative and supportive care has to be provided. But if the patient is uh, being informed how he wants to address the time when such complication develops, suppose a respiratory distress develops, would you like him to get ventilator support, or would he like to uh, uh, like not to intervene? So should we take all these decisions at the time when he is in a full state of mind to take these decisions? First thing. And second, uh, at the time when such complications develops, suppose a patient is in a respiratory distress, then his or her attendants, may not have a consensus between them. The wife may say that okay, you keep on him on the ventilator, whereas parents may feel that okay, this suffering should end. So at such dilemma period, how to deal with? Thank you.
Thank you, Dr. Bharat. I think that was a very valid question. I know that I didn't give any answer to any of my these questions which I posed. Yeah, because this just been thoughts, and we based on that we can generate a lot of discussion. Coming specific to your question, a patient, for example, a patient when we're expecting that see a lung patient, for example, and then you are expecting that this patient will eventually is progressing, and eventually he may develop dyspnea, and we may have to take a decision about how much invasive should we be going about his to help him with dyspnea. Okay, now ideally, and let's talk about ideal situation. In ideal situation, the discussion about 10% of people normally how do people die? 10% of they say figures 10% people they die suddenly. 90% of us, all of us, when we die, we are going to have some kind of chronic problem. There will be period when we live with that disease, and then gradually the disease will progresses and the people die. And often all this becomes messy because there's no preparation done whatsoever from the beginning about planning this eventuality. And it's not a surprise. A patient with CL lung will develop dyspnea at some point of time, and he is going to require more active intervention to help him with dyspnea. So have we initiated the discussion early on with this kind of problem, foreseeing this problem? So when you ask me the ideal situation, but it's not still legal in India. We call it as advanced directive. It's very legal in most of the Western countries, where this discussion starts very early on, especially when the patient is competent, mental capacity is sound. We start this discussion. You got this cancer, and in case this cancer progresses and you reach a stage where you become very dyspneic, and these are the treatment options when we talk about dyspnea. So to what extent do you want to go in case you develop that kind of respiratory distress? So I know this is very tricky when you think about it. It's makes you very uncomfortable. How can you initiate that discussion in a healthy patient? But it all starts from, it may not be the complete picture initially. Slowly we have to start in small ways, but it has to be prepared and developed. It should not be done, as you said, very pointed out very rightly, when the patient is actually dyspneic and saturation is falling, and that's the time. Tell me, what is your decision? Do you want to go for ventilator or not? That is the most unacceptable way of dealing with that situation. So advanced directive is one thing which is practiced so normally in all patients with when you're dealing with the life-limiting illnesses. In our country also, we should start thinking in such lines. And most important thing is documentation. Every time you discuss, document. I discuss this with the patient. I discuss with the family. This is the discussion which we had, and the patient opted for this treatment. And it should be reviewed. What they may say at one point of time changes over a period of time. When they become more and more sick, their priorities changes and their need changes. So it has to be reviewed periodically, and again and again, it should be documented. It may sound very, what you say, it's so much of work. It is not actually. It is a part of your daily discussion. when a physician, as a physician, you're dealing with a patient with life-limiting illnesses, it should be a part of your treatment, planning for his eventuality. I don't know if I
Thank you.
answered you.
It's just that the preparation for the terminal illness should start right from the diagnosis, and we should gradually approach to the problem, bringing in gradually the terminal scenarios and getting consent over it. This is what I can make up.
Absolutely, you put it in a very nice way, put it all together. Yeah, this preparation should not be as come as a surprise. Then there's a conflict because their expectation and we think, oh, it was inevitable, but they don't think like that. They thought maybe they will think like, okay, this one more of those episodes and he'll come around. But because there's no preparation. Yes, you're right. Thank you.
Thank you, ma'am.
Dr. Saurabh, yes.
Hello, Dr. Gayathri, and hello, TIPS team. Madam, we know that early involvement is better, but most of the time the treating physicians are not willing to involve us earlier. I don't know, they have some opinion that the palliative care physician would always talk about death and dying and deterioration and all those things. So they prefer not to involve people earlier. And like I had a recent case where patient was CA colon, and she had a recurrent disease. Again, she was operated. She was 76 years old, and she was operated twice. After the second surgery, she had complete intestinal obstruction, and she was put on parenteral nutrition. But I was called in, I got involved, I tried to tell them everything about the various symptoms which would come over and which we would need to manage from time to time. I also talked to them about hydration and nutrition. Now, the gastroenterologist and the surgical oncologist was very keen on maintaining the TPN till the last. Whereas in between, after a few days of parenteral nutrition, I was of the opinion that gradually we should start counseling them against the feeding, artificial feeding. So there was no, bad exchange of word among the physician, but yes, there was a difference of opinion amongst the team members. So how should we handle that? Even the family, since the family was able to afford it, they also kept on continuing, and probably they believe that they are doing the right thing, and they criticize the counseling against the parental nutrition. So how do we go about it, ma'am?
So, Dr. Saurabh, I think you have raised a very difficult situation which we often see in a medical practice when we are working in a interdisciplinary team in a hospital setup where the different disciplines are involved, and to have them all on this board, it's very difficult to have that consensus. And then you're explaining something to the patient and the family, and totally opposite, contradictory information they get from the treating physician, and they are in kind of a conflict and dilemma. But just for the sake of other participants who are there, what we discussed and reaching that consensus with the patient and the family and the treating physician, it happens in most of the situations. If you prepare, that preparation starts early on, and if you are able to have some kind of discussion with the patient and the family, usually you reach that consensus most of the time. What Dr. Saurabh has mentioned is one of the few very difficult situations where we reach a kind of a dead end. So I don't want to take that, all of you to go home with that example in mind and think that this is not possible. Most of the time, if you have a good communication, open discussion, you reach a consensus actually. It's all about reaching the consensus. So one thing I start with when we do a very open communication with the patient and the family, what are your expectations from me? Now, I've been asked to come and help you, and I'm so and so. What are your expectations from me? So it's very important that we understand their expectations and from us, because when we say that who we are and this is what we're going here for, and what are you expecting for your plan further? So the discussion starts from there, and we have to reach a consensus where we reach a thing about comfort care. at today's condition, your grandmother, with everything happening, the entire goal of care should be what is that we can do to keep her comfortable. She's dying, she's just got probably maybe so much time. And in that time limited period, what is that we want to achieve? The comfort. That consensus we have to reach with the family. And if you are open with this kind of discussion, often we reach that consensus. Dr. Saurabh's situation is a very difficult situation we reach, not very often. I'm sure Dr. Saurabh will also agree. It's a very difficult situation. I think that's the reason that we have to do the series of kind of discussion with our hospital staff. Massive awareness we have to create about this futility of treatment and then the concept of quality of life. This kind of discussion we should keep having with our hospital doctors, and then only we can have that this kind of interdisciplinary, a good interdisciplinary approach. Very rare situation when you have this kind of thing. Sometimes if you are ethically, you feel that you're not agreeing with what is happening, and you're morally, you feel I cannot allow this to happen, and it creates more stress on you than doing good. Very often, it may be sometimes it's advised that you can hand over the care to your colleague who can who accepts to take over as it is. Sometimes it is suggested. Sometimes we feel very uncomfortable doing that because, but if it affects your well-being, sometimes it's advisable to hand over to your senior colleague or someone who can deal this with in a more better way if there's somebody to help you. Another way of looking at it is many Western hospitals, there are a lot of conflicts. This kind of situation may arise, especially in withdrawal of life support, withholding life support, and many good hospitals, they have bioethics committee. You can bring this to bioethics committee and they sit on it and they discuss and they look at the pros and cons and help you to make a decision. These are all very high level things, but basic level, the point I want to make, Saurabh, is yes, it is, I acknowledge it is difficult, and it's but very, very few where you reach a dead end. Most of the time we have to communicate, and I'm sure you are doing this all again and again every day in your practice.
May I add another point? So, in this, there is an interdisciplinary team where you find it difficult to go along with the decision of the gastroenterologist or the specialist. So, I think here, more than there are ethical problems, but still, I think what the specialist would love to hear from you maybe the evidence of parenteral nutrition in gastrointestinal obstruction. So I don't think there is good evidence to give parenteral nutrition or TPN in total intestinal obstruction in advanced malignancy. So I think you can talk to your colleagues with the evidence that you have, whereas you can talk to the family with an empathizing mind. That's what I think you can do.
I think I like your point, Sunil, very much, because we have to show that it is not my view, it's not my personal view. We have to talk about evidence, and that is what matters. And which is true also. We have to always look at the best practice and always look for evidence. And it's even in palliative care, even everything. The things I told you about advanced directive, discussing prognosis, comfort care, even these kind of discussions or evidence have shown. I don't know whether you are aware, the recent ASCO guideline, very clearly they come out with a very consensus guideline in ASCO about all these discussions that it should be started early on. So there's evidence. So it's not your personal view or my personal view. Thank you, Sunil, for telling us.
Madam, I would just like to add one question mark. What about these DNR orders, whether they are legally valid or not, or what is what is your opinion regarding it? Do not resuscitate orders.
Yeah, do not resuscitate order. In the court of law, they always look at your intention. What is your intention to treat? And when you say DNR, first of all, let's not talk legally. Let's understand this from patients and families' point of view. I feel when you talk about this DNR, it's like a menu. When you serve food, you ask for chicken paneer butter masala, chicken paneer, and chili chicken, and you have to tick. and they are made to tick, and often they're left. Maybe I should have tried chili chicken, not chicken butter masala. There, when you give this kind of list, I don't know, have you seen a typical DNR list? Maybe you're saying you're working in a big hospital. It consists of IV fluids, antibiotics, ventilation with no circulatory support, with circulatory support, total mechanical ventilation. Like there's a list, and you have to tick. And it's very traumatic for the family when you tell them about these things and make them tick. And often they're left with the conflict because I chose not to do it. Probably if I had chosen, maybe results would have been different. So what if I had chosen that? So often they live with that guilt. So it's not a very nice thing, and more people are getting away from this, doing this DNR. Rather, they take this approach, what we call it as allowing natural death. So what the discussion should be, your father having advanced cancer, he's 70-year-old, and now at this stage there's no more cure possible, no treatment is now we are going to give. Let the nature take its course. Yeah, and in the process, suppose there is suffering, we'll make sure focus on what is that you can give, not what you cannot give. What is that I can give you to make your father comfortable? So that shift of focus from what you cannot give to what you can give is a more human approach to the whole issue than making the checklist and tick, tick, tick and making them tick. And often they are doing on behalf of patient. It adds to more guilt because patient is often unconscious or not in a position to give that decision in our scenario. Legally, when you look at it, often what protects in the court of law is the intention to, what is your intent? So right now, withholding and withdrawing life support, yes, there is some legal sanctity. It has come, and it is still not formal, but yes, it has almost. We are almost there with that. And advance directive, it's still not legal, but they're looking at it. But other things like resuscitation, not to go for it. All these things are helped if you explain to the family and document it properly. They look at your documentation. So whatever you do, learn to document it, because in the court of law, they look at what is that you recorded on your case sheet, whom did you speak to, and what was your intention of treatment. And that will protect you. Not even informed consent. Suppose you say, I took informed consent, and you see, there's a pre-printed version often we see informed consent, and they make you do sign. They don't even understand what they're signing most of the time. And that, but again, that leads to conflict because they say we didn't understand, they made us sign some document. That's not going to protect you. It's your own documentation about what you explained, what was your goal of treatment to help you.
Thank you, madam, for that excellent conversion of active to passive. Means whether instead of withdrawing support, we are asking what all we will provide.
Yeah, so that's a very important thing which we have to learn to, because very often we say, we're not going to do this, we are not going to do this. But they're why are they looking for help? Because the patient is suffering. कुछ तो करो, they will say. ऑक्सीजन नहीं लगाओगे आप बोल रहे हो तो क्या पेशेंट को सांस का तकलीफ है, कुछ तो करो. So that they are pleading for help. Yeah.
Anybody else? Dr. Tina? Any doubt?
Yes, sir.
Do you have any doubts?
No, sir. Thank you.
So, Dr. Gayathri already talked about 4 ethical principles: respecting autonomy, beneficence and non-maleficence, and justice. In the justice, there are 2 or 3 components. One is Dr. Gayathri already talked about regarding fair allocation of resources. That's one type of justice. And the other one is legal justice. That are what are the laws prevail in your locality. So we have to respect that law. That also comes in justice. And then there is right-based justice. Suppose you are a medical officer in a ESI, ESI corporation, and a patient who is a smoker comes to you with severe exacerbation of breathlessness. He already has COPD, and it is usual that he keeps coming to you maybe once in a 2 months. And at that time, he is severely breathless, and he's coming to you for allowing leave from the job. So you every time you give certificate to that stating the patient is sick, and he can be granted leave on that basis. But this has been repeating for some time, maybe 5 or 6 times. And the next time when he comes with severe exacerbation of breathlessness, will you give leave to the patient? Will you allow absence from the job? What's your opinion?
Could
Anybody?
you please repeat, sir?
Yeah. Sorry, I can't hear you.
Could you please
No, no, no.
repeat? I could not hear.
அடியில புண்ணாகிட்டேன் எனக்கு அசிங்கம் போச்சு. சே மொட்டாக போடாது வண்டியில மொட்டாக.
Sorry, anybody else?
Sir, there is no reason not to give him leave, sir. If he's unable to go, if he's seriously unable to go to work, then how can we not give him that kind of?
Because you know that it is because of his habit of smoking, and you have been asking him to quit the smoking, but he is not obeying, but he keeps coming. So are you saying you will allow leave for that patient?
So maybe we could ask him to at least try a de-addiction program before we give him another certificate.
Okay. Anybody else? So this is here.
Sir, we can,
Sorry, somebody was answering.
we can give him the certificate. We are giving him the sickness certificate. We have found him to be sick at the time we were giving him certificate. Although we know the etiology, what is causing it, that problem, but we are giving certificate for the illness. We can give it.
So this is known as right peace justice. The patient has the right to get absence from the leave because he is genuinely sick. So this is one of the other component of justice. So justice, there are 3 components. One is fair allocation of resources, and the other one is legal justice, and the third one is right peace justice. There are situations when patients are not very much conscious, and in such situation, how will you make or take into consideration the autonomy? What can you do to respect the autonomy? The patient should be fully informed, and so.
Do we consider the nearest relative, Dr. Sunil? Because the patient is unconscious, do we talk to the nearest relative and take the further treatment?
Yeah. Okay.
I think, as rightly said by Madam earlier also, that we should initiate this process right from the beginning. So at the very initial moment, we should ask the concerned person whom he has faith, yeah, whom he allow him to take decisions on his or her part when he is not himself in a situation for giving that consent.
Madam, do you want to add any more points?
Yeah, I think both of you are right. One is that we call it a surrogate decision. The nearest kin, they are legally that they are the surrogate who takes decision. But having said that, as Dr. Bharat mentioned, if this discussion if starts on early, the patient very clearly mentions who would be the surrogate in his when if he is not capable to make a decision. So if that is documented, that's very helpful for the medical professionals at the time of crisis. And generally, they say surrogacy also. There's a different level grading, like who are the best nearest possible surrogate. They say if it is spouse, first is the spouse, then parents, and then siblings, like grading of surrogacy. In different countries, they have defined how who are the best people. So in terms of grading, is spouse and then siblings. No, sorry, first is spouse, then parents and siblings, and then friends. If no one is around, then the state takes the responsibility. They take the responsibility of being the surrogate and decision on behalf of the patient.
I think one of the important thing in our country, if you look at it, Western countries, autonomy is one of the, or it is the overriding principle. The patient himself takes the decisions. But here, usually the family members accompany the patient, and the family member will be taking decisions for the patient. That's very common in our situation. So in uh, in our situation, I think we also have to respect the autonomy of the family also, but still we have to be with the patient side. Dr. Sravanti,
Dr. Stravanti? Dr. Swarnalita?
any question?
Give him a chance to go to the addiction center and get treated for the whatever is having that addiction, habituation to smoking or something.
If there is no more question, we will move on to case presentation. Good afternoon. So again, there were no presenter from participant side. So I have to present a patient story. So this story of 32-year-old man who was recently admitted. He was diagnosed to have left iliac mass 5 months back, and he underwent exploratory laparotomy. And because of widespread metastasis, he underwent iliosigmoid side-to-side anastomosis. And at the time of surgery, they made a diagnosis of carcinoma of the colon. And he also have left supraclavicular lymph node, which indicates he has an advanced malignancy. He came to us with constipation, nausea, and abdominal pain, but he was passing platters. And on examination, the vitals were normal. Abdomen was distended, but it is mostly gaseous distension. Bowel sounds were decreased. And on parectal examination, there was a large pedungulated mass in the rectum. The diagnosis was partial intestinal obstruction. So the patient was managed with injection dexamethasone, pantidine, morphine, haloperidol, enema, and liquid paraffin. For the after 2 days, the patient opened up the bowels and he was passing motion. His abdominal pain decreased, but distension was persisting. His bedbound, he was taking orally fluid and semi-solid, but with less quantity. And psychosocial history, patient is unmarried and he lives with his mother. His father was died 6 years back in an accident. He knows about the disease, but don't know about the present general status. And the family, it's mainly the mother, and the uncle is the decision maker who comes to talk to us regarding each and everything. And he and mother doesn't want to tell us the prognosis to the patient. And this was another thing that uncle discussed with us. He was asking us whether we should take him to medical college for surgical opinion, where he was operated. So is there any ethical dilemma involved in this patient's story? Some of you can start.
Surely one ethical dilemma is there, that the patient attendant does not want the patient to tell about the malignancy, advanced stage of malignancy, but the patient has the right to know about his or his status. So, ideally, the patient should be told about his patient status, although his parents, his families are not willing. As the patient will himself undergo that status of all initial grief, then some supportive care he may be seeking. All the stages he may go through, but it is the right of the patient to know about his status. So this is the ethical dilemma here, that family members does not want to tell him, but the patient has the right to know about it.
Dr. Bharani, then?
Yeah, I was about to ask the same question actually. He just spoke.
Madam?
If the patient is having a good performance course, understand what actually he is.
Dr. Bharani, you are telling something.
Yes. There is not much clarity that the patient is.
Sorry, we can't hear you.
Can you hear me?
Dr. Bharani,
Yeah, can you hear me?
we can't hear you.
Can you type it in the chat?
Sir, if I may, only if the patient knows about his condition can he decide what kind of care he still wants. Does he have any wishes on how his care should go on, what treatment he needs, and or any palliative care that he requires from us. So the patient definitely needs to be told about his condition.
Okay. So in the chat, there is another opinion. Patient autonomy is missing. We should inform the patient about his condition, as he might have a plan what to be done in the last time he has in future. So, madam, can you comment on this?
Dr. Sunil, are you asking me?
Yeah.
Yeah, okay. I think, yeah, this is a very challenging situation once again. One thing which I want to add on to the 4 cardinal principles which we discussed, and we looked at various aspects of those 4 principles of medical ethics. And those principles are really helpful and guided more appropriately when we know the biological prospect of the patient, which means that how at what stage of the illness he is. Because what may apply in the early stage of illness may not be applicable in the later stage of illness. When we say do no harm and do good and all these things, which it may change from patient's condition at the time of when we see the patient. Now, in this patient, I would like to think what exactly is his biological prospect, what is his prognosis. And there's another discussion altogether about how to make a judgment about his prognosis. But say, for example, will he be surprised if he lives for another 1 month or 2 months? Like, say, for example, because now I see that it's a partial obstruction, but already there is a mass, and somehow with some pharmacological management, he's managed soon is going to progress to total obstruction, and total obstruction may not be for another few weeks. So overall, we are speaking about 1 to 2 months of his lifespan. So yeah, you are very right. Patient's autonomy is something very important. But if we just go by patient's autonomy, and as Sunil said very clearly, in our culture, the patients and the family, most of the time, function as a unit. We cannot see them as separate. Unlike in the West, here they work in a unit. And and if you do that, if you see them as separate, sometimes you lose the patient because they'll take care of the patient, and patient will be deprived of your care. We should be very careful when we engage in this kind of discussion only with the patient, ignoring the relatives. It may create more harm to the patient in the process. So somehow we have to have the family on your side and to make them realize. So I totally agree with all of you that the patient's autonomy is compromised here. Yes, we agree that is the ethical dilemma. And if you're talking about, say, 1 to 2 months of his lifespan, and so we are not doing any good to him by taking to another medical college, and obviously he's inoperable. So I don't think there'll be any more surgeries from what I understood from the case study. So there's no any attempt, and I'm not very sure whether is there any scope for colostomy. I'm not very sure. It's already done, so further there will be a higher colostomy and health because if that is still feasible, maybe we can take a surgical opinion. I'm not very sure about that. So the point I want to make here is that when you take such decisions, let's also have very clear our own medical clarity about patients' biological prospect. So because I've seen patients who put them on colostomy, they may live for another few months, then definitely I go for it. So that's a quality of life for him on colostomy, but of course with colostomy bag. But again, the choice should be with the patient. Do you want to live you want to live a life with colostomy bag, or you just all right as it is? There's a lot of these things angle to it which we have to take into consideration. But having done all those sort of things, once you understand what is this all about, the same discussion should initiate with the family. What do you expect? Forget about whether to tell the patient or not. First is about the family. What do you expect? What do you want your son to be? you realize that your son is not going to live for 2 or 3 months. That precious time, what is that you want for your son? So that will really help us to make a kind of effective, meaningful dialogue with the family before we even approach the patient. I don't know, Sunil, you want to add anything?
Um, yeah, actually, in this patient, as Madam told, we have to respect the family's opinion because they are strongly. This is not a solution because the family want to hide information from the patient, which is not a solution. So, if we go against the wish of the family, then that will be a problem. They may take over the patient, and the patient may suffer. So, we have to talk with the family and they should be convinced why we need to talk to the used to the patient. But here the family told we don't want him to know because right now he is very happy and he doesn't have much time. So when the patient came here, actually he was having a very advanced malignancy, and that's why only the exploratory laparotomy and side-to-side anastomosis was done. No chemotherapy was possible, nothing more was possible. So the patient had a very advanced disease. As Madam told, we have to know the what is the stage of the disease. So in this patient, it's a very advanced stage, which the family is very much aware of. But when the patient was not passing motion, stools, then they were little bit apprehensive about that, and they thought something can be done from the surgeon who did surgery previously. But so we talked to the caregivers and told them there may not be much cannot be done, but you can get an opinion. You can go to the surgeon and without the patient, you can go and get an opinion from the surgeon if you want. But don't go with hope that this will be cured or something like that. So they told they will wait for 5-6 days. So here we have to also look the ethical principles of non-maleficence and beneficence, because while we send the patient to a surgeon, we also need to look whether are we doing good to the patient or are we producing more harm to the patient by referring the patient in a very advanced stage. So this need to be discussed. So, and this patient, actually, he was supposed to go today morning to the surgeon, but today morning, when he was his general health was deteriorating, and his peripheries become cold during the rounds. And we talked to the uncle and one of his relatives and told him that we think he is going to die within a few days and maybe within few hours, because he was fully conscious, but his peripheries was only cold. He was speaking, but what happened was he died at 2:20 p.m. today. So I think our decision not to refer the patient to the surgical oncologist or surgeon was right. That's what I said.
I think the message we get here again is, I think we are going to have more detailed classes on communication, I'm sure, Sunil. The whole ethical principle and the conflict and the dilemma arise because there is no effective communication. We think we explained everything. Very often we don't, we fail to, it takes a little bit of time, that explanation, the family conferencing, and, and being very honest and giving them a very honest information. That's very helpful, and so that the outcome is always good when you have this kind of open, honest communication.
Anybody else want to ask anything? So, madam, can you speak about the principle of double effect, because which may also need to be dealt in this session?
Sure. What Sunil mentions is something what we call it as principle of double effect. In certain situation, suppose I have this patient, like Dr. Bharat and I think Bharat mentioned about one patient, advanced cancer lung, and he's started dyspnea, having severe dyspnea, and we know that this patient is not going to be benefited by ventilation. So, as I said, our whole dialogue is about what not to give, but shifting it from what to give. So, obviously, he's breathless, and we need to help him with his breathlessness. Yeah. So, but I'm saying that ventilation is not the answer, because the studies have shown that advanced malignancy, ventilation has very poor outcome, and there is no benefit. So, what is that we can offer to him? Obviously, then we talk about a lot of palliative treatment approach, where we talk about helping the breathlessness with medications like morphine and benzodiazepines. Usually, the medications which we use. I'm sure when you have a class on dyspnea, advanced dyspnea, we will be discussing a lot more about this kind of medications which we use in dyspnea. So, suppose I'm just giving an example of one symptom, dyspnea. So somebody who's dyspneic, having advanced disease, clearly dyspneic, we use medications like injection morphine and midazolam to control his dyspnea. I'm not here looking at the pharmacology, how it's going to be effective, but that is the recommendation. But when you use such medication, often they say remember from our old pharmacological textbook teaching, using morphine and midazolam in dyspnea and take away the respiratory drive. So you're worried about depressing his respiration and hastening his death. So often question is asked, are we going to hasten his death by giving morphine and midazolam? Yeah, you can ask me this question, but suppose we reduce the drive, his respiratory drive, are we going to hasten his death? Again, this is what we call it as double effect. Every pharmacological intervention, forget about advanced malignancy, even in your day-to-day practice, when you give chemotherapy, you know that there's a chance that this patient's blood count will fall. And when the blood count falls, he may develop neutropenia and infection. Sometimes patients die because of infection. This is the side effect or the harmful effect of chemotherapy. But still, you go ahead with chemotherapy, knowing that chemotherapy will cure the patient. And that is the benefit. And benefit outweighs the harmful effect. Yeah. So every intervention we may have has a benefit effect, but sometimes there's also a harmful effect. So what we should be looking at the intention of treatment. So coming back to our patient, advanced malignancy was extremely dyspneic, and he said, "Doctor, do something to take away my of this. I feel as if I'm choking to death. I cannot bear this." So when you give morphine and midazolam, they often feel very comfortable, and they feel more relaxed, and sometimes they go to sleep. But when they go into deeper and deeper sedation, often this dilemma is, are we using this, shortening his life? Which is not true. Several studies have shown that actually doesn't happen. Maybe few minutes, or 1 hour or here and there, but generally overall benefit is much more than this possible side effect that we are shortening his life. And this is the principle of double effect. But the court of law, again, they look at your intention of treatment. What was your intention? My intention here was to give comfort to him by medications which will give comfort. My intention was not to kill him. So they look at the intention of treatment. And that's what we call it a double effect. I'm sure when we discuss dyspnea, delirium, or intractable pain, everywhere you're going to come across this situation where we go into what we call it as palliative sedation. When we sedate the patient to control the symptoms, often this principle, this question is arised. Sunil?
Madam, just it appears that we can say it can be a triple effect also, in the sense that the patient attendants can be convinced that although he is in distress and we cannot do much with the ventilation, we are reducing the pain and suffering by giving the drugs. So this will calm the mental anxiety of parents and attendants also. So, and second thing, by drugs, by reducing, keeping slight sedation, giving anxiolysis, will reduce the oxygen requirement, and probably he may also become less breathlessness. So, additional benefits we are getting out of this.
Absolutely, but I don't know, many of you who are not used to this concept, what we call it as palliative sedation, we'll come to that in detail when we discuss symptom control. It is not that suddenly we push drug and sedate the patient. It is a very gradual and titrating approach which we take. We start with certain base medicine, not better, then we have this dialogue with the patient and the family. Listen, if he's still breathless, shall we go to the next level? But if I go to the next level, he'll be a little sleepy. And they agree, yes, doctor, so long as he's not suffering, we are all right. Then next level, then next. Slowly we titrate gradually and titrate it up, and that's where how we achieve the palliative sedation. Sunil.
Yeah. In palliative sedation, we are giving proportionate sedation. That is, the sedation is proportionate to the suffering of the patient. So you have to give it in titrated fashion. And here, and there are two effects for sedation. One is the patient will get symptom relief, with which he can't achieve with any other intervention. Normally, or the harm which we may produce is even we may hasten the death by giving the sedation. But here we know that both things, it has a good effect and has a bad effect. But at the same time, here our intention is to relieve the suffering of the patient. So even though this may result in death of the patient, we are not withheld, or we can straight away go and do the palliative sedation, because our intention is to relieve the suffering of the patient.
And this is often confused with euthanasia. Euthanasia is, we are not going to detail into that, but just to clarify, euthanasia, there, the intention is to kill the patient upon patient's request. So the doctor gives medication, and the intention is very clear there, to end the life of the patient on patient's request. Here it is not that. So there's a clear difference. Because often people think that in palliative care you give euthanasia, which is not. In fact, most palliative care people, we speak against euthanasia, because we say there are better ways to end suffering than ending someone's life.
So in euthanasia, it is disproportionate sedation. So sedation which is disproportionate to the suffering of the patient. Whereas in palliative sedation, it is proportionate. Sedation is proportionate to the suffering of the patient. So that's the main difference. And the intention is to relieve the suffering in a palliative sedation, whereas to kill the patient in euthanasia. Anybody else want to ask the last question?
Hello.
Yes.
I want to ask one question. Does the age of patient makes any difference when we have to follow the ethics? Like if a same patient, young or old, with same disease, same prognosis, is there any difference between the set of ethics we should follow?
Dr. Harpreet, I can't see you though. Dr. Harpreet, that's a very interesting question. Yeah. This question often arises when you speak about a young child. Suppose I see a lot of pediatric patients, a young baby, under 2-year-old baby, and they say, do everything possible because the child is not supposed to die. Or elderly people, when they say, anyway, he's now 80-year-old. So, yeah, but if you talk about medical ethics, yes, age is guiding factor. When we talk about biological prospect, remember when I mentioned something about the biological prospect. Age is one important factor which is taken into consideration more for the fact that what is his life expectancy based on disease and his performance status. If the age is a healthy elderly, and I will not consider that as a poor biological prospect. Unhealthy elderly, yes. So it all boils down to performance status of the patient more than the age as such. And again, a very elderly person also may say, I want to go for all possible treatment. That is his autonomy. So it is nothing to do, abhi itna booda ho gaya to chalo usko kya karna hai. No, if the patient wishes to go for proper treatment, yes, this is patient's wish. But having said that, when you plan any intervention, you have to look at his biological prospect and his performance status. That will be one guiding factor I can think of immediately when you ask that question. Sunil, any your comment or anyone else want to add on to what I said just now?
Anybody else want to comment?
Dr. Harpreet, I hope you agree because you quiet, so I'm curious
Yes,
about.
I agree, ma'am. I got the
So
point.
in the child is dying and he's suffering. I will not say just because he's child, I'll go do everything possible. I'm producing more harm actually. Doesn't mean that just because he's a child, I have to do everything very aggressive. No, we have to see his condition and then decide.
If there are no more questions, I think we will stop here. And I like to thank Dr. Gayathri and all the others who attended today's session. Thank you all. We'll see you on next Thursday. Yeah.
Thank you,
Bye.
sir. And thank you. I enjoyed interacting with all of you. Thank you.
Thank you, ma'am.
And I request all the participants to present a patient story. Shiba will be contacting you. So please.
Sir.
Yes, Gina.
Sir, so you mentioned palliative care research, sir. How do you think we can do palliative care research, sir?
How can we do palliative care?
How do we do palliative care research, sir?
Ethics, are you talking? No, Gina, are you talking about ethics in palliative care research or
No,
just?
sir. No, sir. Palliative care research, obviously, we need to be in a tertiary care center that has palliative care. But by ourselves, we cannot do any. How would you recommend us to do palliative care research, sir?
Okay, I think that's
Everybody's
one
gone.
area, most of us are struggling with. But I think most of us, even including me, I take the help of colleagues from Western countries. So they know how to do research, but we don't know how to go about that. So we are slowly picking up that. So I think all of us have the interest, but doesn't have much knowledge to do the research. That's what I felt. That may be my perception. Many of you may be good researchers. So I think we have to take the help of others who has been doing research. That's what I felt.
Thank you, sir.
Okay. We will stop here. Thank you all.
Thanks.
Thank you.